All right. Well, hello. This is Chapter 12, the Upper Gastrointestinal System from the 11th edition of the Textbook of Radiographic Positioning and Related Anatomy. This lecture is specific to an upper GI exam, and this PowerPoint presentation is going to begin with our first image of the stomach, and this is actually from figure 12.22 on page 466. This picture shows you the stomach from the front, like if you were looking at the patient. You can see that the esophagus, not yet, you can't see, huh? You can see that the esophagus comes down through the esophagogastric junction, and then food or liquid would enter the stomach, of which there are 3 parts to the stomach, and then it ends up going into the duodenum of the small intestine. This one has a little bit more labeling on it. So the esophagogastric junction is the area between the esophagus and the stomach. You can see you've got the fundus is the most superior posterior portion of the stomach, and that'll make sense in a few minutes, but that area of the stomach is the most superior, meaning the highest, and it also sits posterior when we look at a picture from the side of the patient. Then you've got the body of the stomach, and then you've got the fundus of the stomach, which is the last, I'm sorry, my bad. The fundus, the body, and the pylorus. And those are the 3 main sections of the stomach, and that leads into the first section of the small intestine, which is the duodenum. You can see some of this labeling. You've got the greater curvature of the stomach, the lesser curvature, the angular notch, the pyloric antrum, the esophagogastric junction. Just more anatomy that is important when we're looking at anything with the images that we take, but specifically we will look at the air and the barium distribution within the stomach when the patient turns in different positions. This is the same image that was previously shown, except now the patient does have barium in their stomach. So you can see the fundus is this air-filled portion. You can see the body of the stomach and the pylorus, and then you've got the duodenal bulb right here, and this is the duodenum. This is the C loop of the duodenum, which is the shortest but widest segment of the small intestine. As far as the stomach orientation, this picture relates to on 467, figure 12.26. This is looking at the stomach from the front of the patient. So this is the patient's right side, patient's left side. And then if that patient turns sideways in a lateral view, and this is their spine, so the posterior aspect, and this is their stomach or abdomen. So, I'm sorry, their abdomen, that would be the anterior aspect. So the fundus is the most superior portion. That kind of stands out. But it also, if you look at it from the side, the fundus tends to sit more posterior than the body and the pylorus. So that really comes into play with where the barium falls when the patient is in different body positions, different radiographic positions as well. So fundus is the most superior. The body is the biggest section of the stomach, and it's between the fundus and the pylorus. And then the pylorus is the most inferior portion, meaning that it sits the lowest in a patient. Okay, so fundus is most superior and posterior. Body sits anterior and inferior to the fundus, and the pylorus sits posterior and distal to the body. All right, this next picture comes from page 467 as well. So this is figure 12.29 on page 467, and this is important because this shows you where the air is in the patient versus the barium and how it's distributed when the patient is in a different position, meaning if they're supine, if they were prone or if they were erect. The black represents air, the white represents the barium. So when a patient is supine or on their back, supine meaning when we look at positioning, this would be like the AP and the LPO. Both of those positions, they would be on their spine. Notice how, because the fundus sits the most superior and posterior, the barium tends to fill in the fundus of the stomach. The body and the pylorus tend to be full of air. When the patient is prone or flips over onto their stomach, then you have air in the fundus and barium fills the body and the pylorus. And when the patient is erect, you get a distinct air fluid level, and you can see air is in the fundus, barium is in the body and the pylorus, but you know that this is erect compared to the other two because you have that solid line. Okay, this is important because if you have to repeat an image, you need to know where the barium versus the air is so that you could tell which image would need to be repeated if that was the case. So when we look at the images here, they're asking out of this A or B, which one was taken prone and which one is supine. So if you remember from the last slide, when a patient is supine, the fundus is full of barium, and when they're prone, the fundus is full of air, okay, because it sits superior and posterior. So the one where the fundus is full of barium is this one right here, which means in this picture, the patient was lying on their back or in an AP position. In this picture, you can see that the fundus tends to be full of air, and we have barium in the body and the pylorus. So in this particular picture, the patient would be prone. Actually, we can tell by, or I can tell by looking at the spine that they're actually in an oblique position, but they are more face down versus on their back. So they are rolling towards a prone position. This actually is most likely an RAO position, but out of what they're asking you, I would say that A is prone, B is supine. So those are things that we have to look at because it's important, especially when you're trying to repeat an image, to know that you're repeating the correct image. So this one, barium in the fundus, so the patient is supine. This one is an RAO, which the patient is closer to being prone, and you've got air in the fundus. All right, the duodenum. This represents the shortest but widest segment. We've spoken of this before in another lecture, and it is approximately 10 inches long. And after it comes out of the pylorus of the stomach, it enters the C loop of the duodenum, and it's named that because of its shape. And the C loop of the duodenum hugs the head of the pancreas, and they refer to that as the romance of the abdomen. Now, this does lie retroperitoneal, meaning behind the peritoneum. Okay, and when we look at the duodenum, notice that you've got the pylorus here, you've got the duodenal cap or bulb, and then you've got the superior portion of the duodenum, the descending portion of the duodenum, which is important because that's where bile and some of the enzymes from the pancreas dump into the descending portion. Then you've got the horizontal portion, and then the ascending portion. So in that short 10-inch span, you've got 4 sections. You've got the superior, the descending, horizontal, and ascending. And that leads into the jejunum, which is the second portion of the small intestine that has the microvilli in there that make it appear feathery. Okay. So on this, they're just testing, is the patient supine or prone? When we look at this, we can see that there's air in the fundus of the stomach. So with air in the fundus, the patient would have to be in a prone position. You can also look at the pelvis and tell that that does look different. Most likely this patient was in a PA position when this image was taken. When we look at mechanical digestion, this comes from page 469, table 12.3. You can see that in the oral cavity, we have mastication, which we spoke of, which is chewing, deglutition, which is swallowing. In the pharynx and the esophagus, the pharynx basically is where when you swallow, food would enter the pharynx. Remember, there's three parts: the nasopharynx, oropharynx, and laryngopharynx. In the esophagus, we mentioned that fluids tend to pass quickly within 1 second, and they pass via gravity. Solids take a little bit longer, typically 4 to 8 seconds, and they pass with gravity and peristalsis, which are those alternating waves of contraction and dilatation that propel food through the digestive system. Food then enters the stomach, where there is mixing and peristalsis, and it turns it into chyme. And then after it exits the stomach, it goes through the small intestine for approximately 3 to 5 hours. And in there you have rhythmic segmentation, which is a churning, and it moves through by peristalsis. Most of your absorption takes place in the small intestine. Up to that, you have ingestion and or digestion in the oral cavity, passes into the pharynx, into the esophagus, the stomach, the small intestine. So all of that does take place, but most of the absorption of vitamins and nutrients takes place in the small intestine. And then the large intestine is basically where the waste product that is left over is compacted into fecal material. The water is pulled from the fecal material in the large intestine, and then there is elimination. So I would say that the main function of the small intestine is the absorption of nutrients, and the main function of the large intestine is elimination of waste. Basically, defecation is what happens when all the excess materials from your food that you've eaten that are not used, they enter the large intestine. Water is removed so that it becomes a more solid material, and that is where fecal matter is formed, and the purpose is to eliminate that fecal matter. As far as our body habituses, we've talked about this. It's the general form and frame of the patient. So on page 471, you can see they do show a stenic patient, a hyperstenic patient, and then they show one that they consider hypo or astenic. Now, I'm not convinced that these numbers are accurate, because according to this book, granted in 2018, 50% of the population is considered stenic, and I would argue those numbers are not relative today. I would say that they're 50% of the population is not stenic, just like I'm not convinced that only 5% of the population is considered hyperstenic. Okay, they still list those numbers, but I'm not sure that they are valid. We've talked before about the framework determines where organs lie. We talked about it when we looked at the lungs, when we were imaging chest. Okay. Now that we're looking at the upper GI system, we tend to look a little bit more at stomach. So in a hyperstenic patient, the stomach sits more horizontal in that type of patient versus any of the other. Typically in a stenic patient, the stomach has a J hook to it, and that J hook becomes more pronounced and drops a little lower as we decrease in body habitus. So J hook in a stenic patient, more pronounced J hook in a hypostenic patient, and then the most pronounced in an astenic patient. Typically, their organs tend to drop into the pelvic cavity. If you were imaging, you'll see the stomach drop very low in the pelvic cavity compared to a stenic or hyperstenic patient. Usually on a hyperstenic patient, their stomach sits near horizontal. All right, so we look at this. The stomach is high and transverse on a hyperstenic, like I said, near horizontal. Tends to have a J shape in a stenic patient, and then as we get even smaller, it's more pronounced J shape and sits lower. Typically in a stenic patient, the duodenal bulb falls at the level of L1, L2. In the large intestine, on a stenic patient, the left colic flexure or the left splenic flexure tends to sit higher than the right, again because of the liver. The large intestine in a hypo or astenic patient sits relatively low, closer to the pelvis. And then in a hyperstenic patient, the large intestine is widely distributed because remember, the large intestine tends to line the periphery or the outside edge of the patient. Okay, so the large intestine tends to move to the periphery of the patient. Here again, they're showing you a stenic patient, how the duodenal bulb sits at the level of L1, L2. On a hyperstenic patient, it sits a little bit higher at T11, T12. In a hypo or astenic patient, it sits lower than L1, L2 at L3, L4. Okay, when we do talk and position for upper GI, I will tell you that we focus on a stenic patient. And if you can position for a stenic patient, then typically you are able to position for a hyper or hypostenic patient because you have the luxury of looking at the monitor during fluoro and being able to see exactly where that stomach is in relation to the pelvis or any other landmark that you choose to use in the abdomen. You can look at the monitor and see where the stomach lies in relation to that. Almost like you get a sneak peek. All right, this is referencing the 3-body habitus they have listed on page 471. I will tell you in the book that you have versus this slide, they use this picture that they have up here in the PowerPoint is an old picture. I don't love the patients referencing the body habitus, but in your edition on page 471, especially the hyperstenic patient, that is very much spot on what a hyperstenic patient in their amoeba gown would look like. So in that particular patient in 12.39, a hyperstenic body type, they have broad shoulders and hips, typically a short torso, and the abdominal cavity is widest at the upper margin, meaning in their at the top near the diaphragm. The duodenal bulb on that patient is to the right of midline, about the level of T11, T12, because again, the stomach sits more horizontal. On a stenic patient, the duodenal bulb is slightly to the right of midline at the level of L1, L2. And then on a hypo or astenic patient, the duodenal bulb is at midline and tends to sit at the level of L3, L4. You can see way more significant J hook on this patient. This does look like a J, but not as pronounced as this. And in this patient, the stomach is definitely more horizontal. So horizontal on a hyperstenic, J hook on a stenic, more significantly pronounced J hook on a hypo or astenic patient. As far as the upper GI procedure, when we talk about that, we will notice that this is an AP abdomen with no contrast media. okay? Because in this, you can see there's some air in the intestines. You can see this right here. You can see the pelvis, or at least make out the pelvis. You can see the spine. We can see the psoas muscles right here. But everything, liver, all of that looks to be about the same mass density, meaning there's not a lot of differentiation in here. That's why, in order to see a hollow organ, you have to put contrast media in there so that it stands out against the other anatomy. Okay, so in order to do an upper GI or image any hollow organ, you would have to put contrast media in it. So that could be, contrast media could be injected, like into a vein. It could be ingested, like if the patient drinks. And at times, the contrast media could possibly be inhaled, depending on what study you were trying to accomplish. I would say that most of the time with us, the contrast media is ingested, taken by mouth, and oftentimes it is injected by needle and syringe. We had talked in the other lecture video that a upper GI procedure could be either single contrast, where we use one positive contrast media, and that would either be barium sulfate, which is a colloidal suspension, mixed to the consistency of the radiologist or the fluoroscopist preference, or you could use the water-soluble iodinated contrast media if the patient did not have any iodine allergies or iodine issues. So this single contrast means one contrast media, and I know it lists barium, but it could also be the water-soluble iodinated contrast. For a double contrast upper GI, we have both a positive and a negative contrast media. So the positive contrast media could be either barium sulfate or the water-soluble iodinated contrast. Either of those are positive. And then our negative contrast media would be our carbon dioxide crystals or room air. You can see this is a double contrast study. So you've got barium in the fundus, and you've got air in the bulk of the body and the pylorus. The pylorus has got a little bit of barium in there as it's passing through into the small intestine, but this is a double contrast study. You can see on this double contrast, you can see the mucosal folds in the stomach. That is your rugae. And rugae allow for expansion of the stomach so that it can hold more food. You also have rugae in your bladder. So this is the fundus full of barium. The body and pylorus tend to be full of air. And then we have barium in the C-loop of the duodenum. This would represent the duodenal bulb. And then you've got superior portion, descending portion, transverse portion, horizontal portion, my bad, and then ascending portion. So this is the C-loop of the duodenum. This is the rugae in the stomach, because when a patient comes for a study of the upper GI, they are NPO, or they have had nothing by mouth for a minimum of 8 hours. They are also not allowed to chew gum or smoke cigarettes. Some clinical indications for an upper GI. So these are all listed in your chapter. These are your pathologies. So they reference you. The patient could have a peptic ulcer. They could have a hiatal hernia. They could have diverticula, which are outpouchings of the intestinal wall or of the stomach. They could have gastritis, which is inflammation of the stomach, the lining, inflammation of the lining or the mucosa of the stomach. they could have a tumor that they're trying to image, and or the patient could have what's called a bezoar. Now, a bezoar, the easiest way I can describe that, it's almost like a human hairball. It's a mass of undigested material that gets trapped in the stomach. And that undigested material could be hair, could be vegetable fibers like from celery, or it could be wood products. And what happens is that builds up over time, and then it forms an obstruction in the stomach. And there's two types of bezoars. There are trichobezoars, and that is where the patient ingests hair. Now that might sound weird, but I'm sure you've seen patients that chew on their own hair. Little kids tend to do that. That's not really good because your body is not designed to break down hair. So if they ingest the hair or they end up putting it in their mouth like that, it can end up building up in the stomach. And then a phytobezoar is ingested vegetable fibers or seeds. And if the patient is not able to break that down appropriately, like celery fibers, like spaghetti squash, there's probably something else that's just not coming to me right now, but those types of patients could end up with a mass of undigested material, and that would be considered a bezoar. So truly, it is like a human hairball. These are some images that go along with those pathologies. This is a trichobezoar, which is ingested hair. Diverticula, this is an outpouching of the duodenum. Remember, diverticula are outpouching. Polyps tend to project inward. A sliding hiatal hernia, meaning sometimes the hiatal hernia is present, maybe when the patient's laying down, and then when the patient stands up, that sliding hiatal hernia actually goes the opposite way, and you're not going to visualize it because that portion of the stomach would be below the diaphragm. This is a Schatzki's ring. That is a radiographic sign. It's a ring of tissue that lines the distal esophagus that ends up protruding into the lumen of the esophagus. So it is a definitive sign of a sliding hiatal hernia. And again, these are all on your pathologies, which for the upper GI start on page 483 and continue through page 485. Gastritis. All right, and that takes us to our positioning and our prep for an upper GI procedure. Again, I feel like, as always, our responsibilities during a fluoro study are to prepare the room, prepare the contrast media, obtain the clinical history, explain the procedure to the patient, and really, ultimately, we assist both the fluoroscopist and the patient with anything that is needed. The patient prep for an upper GI, this can be found on page 486. And the goal always when you're imaging a hollow organ is to start with that organ completely empty. So in order to do that for an upper GI, the patient is told that they are NPO, which means non per os. It's Latin for nothing by mouth, typically from midnight on. It should be that the patient is without food or fluids for a minimum of 8 hours prior to the exam. They are also not allowed to chew gum or smoke cigarettes during that period, because what happens is when they chew gum or smoke, it increases their gastric secretions and it causes them to salivate, which can prevent the barium from sticking to the mucosal lining in the stomach, and it can also create excessive air in the organ, which we do not want excessive air. Okay, so NPO 8 hours prior, no gum chewing, no smoking, and as always, we would determine pregnancy on the patient. Now, I know we jumped from that to introduce and assist the fluoroscopist, but remember in the other lecture, I mentioned that if we are doing a fluoro procedure, once we give the patient contrast media, we basically cannot undo that process until they eliminate the contrast. So based on that, we have to do what is called a scout image. And that scout image is simply, for this procedure, an AP supine abdomen based on your patient's body habitus. You would either do a T-shot or 2 IRs placed landscape. Okay, you're basically going to take just an AP supine abdomen on your patient to not only confirm that they followed their prep, but it also acts as proof so that if the radiologist is reading something on the exam and the overhead images that we did and they question something, they have the capability to look at our scout image to determine possibly if the issue was there prior to contrast being given or if it's not noticeable without the contrast being given. So your scout image is literally almost like a covering of the patient or a covering of the radiologist, like an insurance policy to show what the patient looked like before they were given barium. It's usually marked or annotated with the word scout because you're kind of scouting out what the patient looks like before you give them the barium. So those images have to be taken prior to and cleared by someone with more authority, typically a lead technologist, or the radiologist will clear those images before we begin the procedure. This is where you ask the patient if they followed their prep. If they tell you yes, I would ask them, what was that? And they'll usually say, oh my gosh, I haven't had anything to eat since last night. I'm starving. And then you would take a scout image to prove that the patient had nothing in their stomach. There was nothing obvious showing up, not excessive air in there. And then you would be able to proceed with the procedure at that point. Once that scout is done and cleared, you would stand the table up. You would pull the bucky all the way down. So you brought out the bucky slot shield. You would make sure that the footboard was on the table and that it was able to support the patient. You would place the patient on the footboard in an erect LPO position with the barium in their left hand. When the radiologist or fluoroscopist comes in, you would introduce the two, and at that point your job is mainly to observe and assist either the fluoroscopist or the patient. Here we have a picture of the footboard that the patient's standing on. We can see the bucky is here, but again, it's not all the way down because this bucky slot shield is not all the way fully extended. The monitor is there so that we can see exactly what's going on when the patient does drink. This is the control panel for the fluoro tube, which is located under the table. These are the lead drapes that fall down, but unfortunately when the fluoro tube is, or the fluoro table is in this orientation, meaning it's vertical, those lead drapes tend to fall this way versus this way. But notice the fluoroscopist is attempting to stand closer this way and not out this way, because remember, scatter is created in the patient and then it can scatter at any angle. At some point, they will lay the table down and then the patient will continue to drink more barium. The entire time, pictures are being made while the patient is upright and moving as the fluoroscopist directs, and while the patient is lying down and moving as the fluoroscopist directs. Okay. This summary, they reference, you've got the clinical history of the patient with what's going on, how long has that been going on, getting all the details for the radiologist. The body habitus definitely affects your positioning. During fluoroscopy, you should identify positioning landmarks. Look where the stomach is in relation to the pelvis. Look where the stomach is in relation to the iliac crest. Those kind of things, you get a free sneak peek when you're doing fluoro. If you're smart, you'll look at the monitor at least a few times to make sure you know where you would actually position when you go to take your images. We want to utilize a high KVP, typically between 100 to 125 for single contrast studies, 90 to 100 for double contrast procedures. As always, we try to utilize a short exposure time so that we help control any voluntary motion. What is the routine for an upper GI series? These 4 images here are what we would do for a routine upper GI. We would do an AP, an LPO, an RAO, and a right lateral. So these are considered overhead images. What is meant by that? It means those are the images that are taken after fluoroscopy. So remember, fluoroscopy is radiography in motion. These images are still or static images, meaning they're like a photograph, whereas fluoro would be like a video. So these are the 4 images that we would take on a patient, and we would go in this specific order. Our first one is an AP upper GI. And in your book, this one is not the PA on 495, but it's actually the last page in the chapter. It's on page 498. And this is your upper GI projection, AP projection, I'm sorry. So once the fluoroscopist leaves the room, I would ask the patient to go ahead and lie on their back. You would move the fluoro tower back. As you can see in this image, it's moved away from the patient. Nothing is here either. You would get out your image receptor and place that in your bucky. You would take the barium from the patient. You would kind of just clean up a little bit, but you're still going to have to take those images of your patient. So I would have the patient lie on their back. You're going to be using a 14 by 17, likely in a portrait position. Your KVP range, we said, is 100 to 125 for single and 90 to 100 for double. I recognize that it says 80 to 90 for water soluble, but I would tell you that I would stick with 90 to 100 for either double or water soluble. So on an AP upper GI for single contrast, we use 110 kVp at 2 mass. And for double or water soluble, we use 90 kVp at 2 mass. Okay, 110 at 2 for single, 90 at 2 for double or water soluble. That's what your control panel would be set at. You're at a 40-inch SID. Patient is lying on the table relatively straight and in the middle. And notice under your central ray, you have a stenic body type, a hyperstenic body type, and an astenic body type. We are only going to practice the positioning for a stenic patient. So when we practice, everybody in class, whether you are or are not we are going to act as if you are stenic. Okay? So on a stenic patient, the central ray is to the level of L1, and that is found midway between the xiphoid tip and the lower border of the ribs. They also reference midway between midline and the left lateral margin of the abdomen. But what I will tell you and show you is that you would position using what I call the W method. All right, and that doesn't really make sense until you see it, but you're basically you're placing your middle fingers. One goes on the lower border of the ribs, the other one goes on the xiphoid process, and you put your two thumbs together, and that forms your W. Okay, I know it sounds weird on this. I can't really show you it, but if you watch the positioning videos, you will see what I mean, and it does work. Once you place that central ray at the level of L1, you would go back and have the patient take in a breath, blow that breath all out, hold it out, don't breathe, and beep. On this particular image, you have to demonstrate the entire stomach and duodenum, the diaphragm and lower lung fields, and that is so that if there is a hiatal hernia, it's demonstrated. But in this picture, you should have barium in the fundus and air in the body and pylorus. The reason for that is because the patient is on their spine. And remember, we said that barium will fall in the fundus because it sits the most superior and posterior. Okay, so on an AP upper GI, the supine position is all we've talked about first. The fundus will be full of barium, the body and the pylorus will be full of air. Now, that little inset picture that you see in figure 12.103, they show you the patient lying on the table, but notice that the table, the patient's head is down, the feet are up. So that patient is in a Trendelenburg position. And if you look at the bottom of page 498 above the evaluation criteria box, notice it says an alternative AP, a slight Trendelenburg position. That may be necessary to fill the fundus on a thin asthenic patient. A lot of texts do this, though, to demonstrate the hiatal hernia, especially a sliding hiatal hernia, because when you drop the head of the bed and that patient is a little bit slightly head down, if they had a sliding hiatal hernia, then a portion of the stomach would come up through the diaphragm, and you would actually see it above the diaphragm, and that would be the best way to demonstrate that. Okay, so a hiatal hernia can be demonstrated best in an AP Trendelenburg position. And if you look under the clinical indications at the top of 498, it says the same thing. So normally we're just going to do the AP supine, but if the radiologist suspected hiatal hernia when they were doing their fluoro, they could request that you do an additional image in the Trendelenburg position. After the AP supine, we do an LPO, and that is actually back on page 497. You're still at 40 inches, still on a 14 by 17 portrait, and I will add on the AP, the 14 by 17 portrait for the AP, the collimation is open to 14 by 17. Once you're done with the AP, all the other positions, the LPO, the RAO, and the right lateral, you are collimated to a 10 by 12 portrait. Okay, so we collimate to a 10 by 12 portrait. The technique on an LPO is 110 kVp at 2 mass for a single, 90 kVp at 2 mass for double or water soluble. Kind of interesting that so far most of the things we've talked about with regard to fluoro studies on the APs, it's been 110 at 2, and I will tell you the laterals are typically 110 at 4, or dropping the kVp for double or water soluble. So worst case scenario during a fluoro procedure, if you have no clue what to use, 110 at 2 if they're not in a lateral, 110 at 4 if they are in a lateral, pretty much would work on all stenic patients. We do use left marker, and we place that left marker down. On this LPO, once we've collimated to 10 by 12, notice it says that the patient is rotated between 30 and 60 degrees from supine in an LPO position. There's more rotation required for a hyperstenic patient versus an astenic patient. That's why the range. I would tell you for a stenic patient, it's going to be right in the middle at 45 degrees. The reason for that is on a hyperstenic patient, it takes more rotation to move the stomach into the position you need it to be. So for a stenic patient, we're going to center again to L1, which is found midway between the xiphoid tip and the lower border of the ribs. And again, we're going to use that W method. When we get done with that image, you should see the entire stomach and duodenum. The fundus will still be full of barium because the patient is still relatively on their spine. And in this particular picture, the fundus will be full of barium, just like it was on the AP. After that, the patient would roll into an RAO, and that is on page 494. All right, RAO is the third position, and that is on page 494. Still at a 40-inch SID, still collimated to a 10 by 12 portrait, still using left marker. So I will tell you that, I'll tell you this, so on the AP, it's left marker, it's down. On the LPO, it's left marker, down. On the RAO, it's left marker, but it's up, kind of like the picture is in the book on page 494. That is correct. The other two, I don't feel like they visualize those correctly. On the LPO and the AP they actually use right marker. We're not. We're going to use the left marker on the opposite side. So left marker down. The LPO, I'm okay with them left marker, but it's in the opposite location. It would be down at the bottom. And then the RAO, it's left marker, but it's up, just like they have it on 494. Our technique is the same as it's been, 110 at 2 for a single contrast study, 90 at 2 for double or water soluble. The patient lies on their stomach with their right arm down behind them. Their left arm is up in front. And notice in this one it says that the part is rotated from 40 to 70 degrees. Typically more rotation on the hyperstenic patient, less for the astenic patient. On the stenic body habitus, we are rotating the patient 45 to 55 degree oblique, and we're still centering to the level of L1 which is now found 2 inches, 1 to 2 inches above the lower border of the rib, midway between the spine and the upside lateral border of the abdomen. That is a mouthful. I can tell you that it sounds way more intimidating than it is. You're basically taking the left side of the patient and you're finding the bottom of the lower border of the ribs, going 1 to 2 inches above that, and then halfway between the left side of the patient. That's ultimately what it breaks down to in what you're doing. The criteria that we're looking for on this, now the fundus is going to be full of air because the patient is prone. The duodenal bulb will be in profile on this particular image. So the fundus is full of air, the body and the pylorus have barium, and the duodenal bulb is in profile, which is right here. This is the duodenal bulb, this is beginning of the C loop. So right here, that duodenal bulb or duodenal cap is in profile if this is done correctly. Our last image is a right lateral. I know on the esophagogram we said that it could be either lateral, but for the upper GI it is definitely the right lateral that is done. Okay, so patient lies on their right side. Patient lies on their right side. You're still collimated to a 10 by 12 portrait. You're still at a 40-inch SID. And now your technique would be 110 at 4 for a single contrast, or 100 at 4 for double or water soluble. Okay, 110 at 4 for single, 100 at 4 for double or water soluble. Patients lying in a complete lateral position, meaning their back is straight, shoulders on top of each other, hips on top of each other, and you are centering to level of L1, which is now found 1 to 1.5 inches above the lower border of the ribs. I'm sorry. My dog is pacing and driving me crazy. On this position, the patient's in a right lateral, back straight, hips and shoulders on top of each other, meaning both shoulders in line with one another, both hips in line with one another. Now you're centered at the bottom of the ribs, but you're 1 to 1.5 inches anterior to mid-coronal. What's going to happen is that in this particular image, the barium is going to cause the stomach to fall forward. So when it falls forward like that, instead of centering right in the middle, the mid-coronal of the patient, you actually are moving the central ray 1 to 1.5 inches anterior to mid-coronal. Okay, because you can see how the barium kind of fills and makes the stomach fall forward. Here's the spine, nice and straight, and the barium causes the stomach to fall forward because it's heavy. This is the only view that demonstrates the retrogastric space. This is the only view to show behind the stomach. So any tumors, anything they might be looking at that could be behind the stomach, this is the only view that would show that. All right, so 4 views for an upper GI: AP, LPO, RAO, and right lateral in that order. Technique for the first 3 is 110 at 2 for single, 90 at 2 for double or water soluble, and the lateral is 110 at 4 for single, 100 at 4 for double or water soluble. Make sure you write down any questions you may have with this. Once we're on ground together, we will look at the positioning together. Make sure you watch the positioning videos because they really do make it a little bit more clear. And I will see you guys soon. Have a good day.